Welcome to this week's episode of the Caregivers podcast. I'm your host, Dr. Mark Ropeleski, and you can call me Dr. Mark. Today's guest is a very special one because we're going to talk about a very special topic. Hospice is one of the most feared words in caregiving. To a lot of families, it sounds like giving up, like the end, like the moment there's nothing left to do. But hospice is also one of the most misunderstood parts of this stage of life. It's not just about dying. It's about comfort, clarity, and how someone's cared for when recovery is no longer the goal. Today, we're talking with Les Harp, a hospice nurse many people know online as the hospice guy. We're talking about what families get wrong about hospice, how to know when it's time, and what the hospice team actually does. We're also talking about what this final stage asks of people who love you. If your family has ever feared what hospice might mean for someone you love, this episode's for you. And before we begin, please subscribe to the Caregivers podcast on Apple, Spotify, or wherever you listen. It's free, it takes just a second, and it's the best way to support the show. Les Harp, welcome to the Caregivers podcast. I'm so happy you're with us today.
Thank you, sir. I appreciate it. Thanks for the invite. I'm looking forward to it.
Yeah, we've been looking forward to this conversation, and I'd like to, in the tradition of the podcast, jump right into it, and about midway, take a break for our production team who are illustrious and always listening and to get a few questions in themselves. So let's tell us, before you got into the work that you know now and as a hospice nurse, what was it in your own life that's brought you close to death, dying, and the final stages of caregiving that inform where you are now?
So it's a little bit of a lengthy story. I'll try to keep it brief. But in 2004, I actually was working for Home Depot. I worked in the retail sales game. I grew up with my parents owning their own flooring store, so I naturally kind of went into that line of business. So I was a flooring expert. I'm an expert on carpet and ceramic tile and hardwood. If you ever have questions, I could probably still answer a bunch of those. But in 2004, I got a call from my wife. My wife, Cassie, was a nurse, and I was obviously not. I worked at Home Depot, and she had just had a doctor's appointment, a routine doctor's appointment, but they found what she had thought was a hemorrhoid, and it was not a hemorrhoid. It was a tumor. So she was diagnosed with colorectal cancer, and immediately we were thrust into the treatments, the scans. Hers had already metastasized by the time they found it. Like a lot of nurses and healthcare professionals, she put her health to the side to take care of other people for a long time and ignored the things that probably her body was telling her, like a lot of us did.
Meaning it spread.
Yes, it had already spread. It had already spread to her lungs and lymph nodes. So it was stage 4 when it was diagnosed. And so 13 months later, we found ourselves at the end of all treatment possibilities. The cancer had moved into her brain, and we were told it's time to go on hospice. And at that point, I had really had no experience with hospice, death, dying, any of those end-of-life issues. And so we were thrust into it. It was a lot of really fast, people coming in, people admitting her at home, a lot of discussions, a lot of decisions were made that we hadn't really given much thought to because we thought, we're fighting cancer, right? The goal is to live. And so, like so many people that are in that situation, end-of-life issues, end-of-life decisions were not even discussed until we got to the very end, which is another thing that I try to talk about, and I know you try to talk about. There's a lot of us educating about talking about these things and having these discussions earlier and making plans, right? We plan for almost everything else we do in life, but we're the most hesitant and resistant, it seems, to planning for death and the end of our lives, even though all of us are going to reach that point at some point. None of us make it out of here alive. So that's how I was introduced. And of course, I was introduced to caregiving at the same time because you become, as the spouse of a terminally ill or chronically ill person, you become a caregiver. You're kind of the de facto default caregiver. So that was thrust on me as well. In 2005, 13 months after she was diagnosed, she was on hospice, and a couple of weeks later, she died at home. And so after all of that 13 months of furious activity, I was left in silence, right? And like so many of us are left when we're grieving, especially what I've found with widowhood, with when you lose your spouse, you lose your life in essence, right? You have to pick up pieces that may not even be there anymore. There are missing pieces. And so trying to move forward from that is a lot of silence, because a lot of people don't know how to be with someone who is grieving and be present with that grief that they're experiencing, because it's very uncomfortable. We don't know what to say because, again, we don't talk about these things. So I was left in a lot of silence and reflection, and I had resisted. My wife, Cassie, had tried to get me to go to nursing school. She said, go be a nurse. You're smart, you're caring, you're empathetic. And I didn't want to deal with blood, poop, pee, right? I didn't want to deal with those nursey type things that I saw her dealing with. But in that silence, I reflected and I thought, all the things that I didn't want to deal with and didn't want to do and was resistant in becoming a nurse, caused me that resistance, I did with her. I was doing all those things with her. And so when I look back, I thought, if I can do that with the most important person in my life, I can do it with strangers, right? Because in essence, when we meet families, they are strangers to us. When we meet patients, they are strangers to us. And I learned in hospice, once I get into hospice, they don't stay that way, right? They don't stay strangers, but they are at that point. So I thought, I can do that. And so I went to nursing school with the intent of becoming a hospice nurse. And the reason why was because when I did that reflection, I looked back and I thought, where was the biggest difference made from healthcare professionals in this whole journey that we had, this very short journey that we had? And the thing that stuck out to me the most was the hospice staff. It was the hospice nurse. It was the chaplain, the social worker coming in, the aide that came in to give my wife a bath, right? The most caring, empathetic piece of the healthcare system that I experienced, and I would say we experienced during that time. And so that was my intent, was to become a hospice nurse. And so I did. I went to school and I got told after I graduated, you need to spend about a year in the hospital at least, getting your clinical skills built up. And so I did that. And pretty much the day that I hit my 1-year anniversary at the hospital I was at in med-surg, I started cold calling hospices and saying, hey, what do I have to do to come work in hospice? And so I got hired at a hospice here locally in Texas where I live. I was very fortunate that I was placed under mentorship of a hospice nurse that had already been doing hospice for 15, 16 years by the time I started. Mm-hmm. Yeah, I'm a huge advocate for mentorship, but that's a whole nother conversation, obviously. But I was very fortunate that I got to learn the way hospice should be done, right? And there are definitely, obviously, in the United States here, we just got announced that we have a moratorium on new hospices. So we are in the spotlight for fraud and waste and abuse. But there are definitely hospices, and the majority of the hospices we have are doing hospice with a clean heart for the right reasons and trying to play by the rules. So I got fortunate that I was able to learn how to do that very early in my career. And it helped me identify the places to avoid as well. And 2010, which was the same year I started in hospice, because I graduated in 2009. In 2010, I started in hospice and I met what would become my wife, who would become my wife, Sonia. And we had a slower courtship, right? Because I was still in the middle of grief. I'm still dealing with grief. I'm making some good decisions, some not great decisions in my life. But we had a long courtship, and in 2013, we decided we would get married. We had both been married before, so we didn't want a big wedding. We went to our favorite place in the world, which is Estes Park, Rocky Mountain National Park in Colorado, and we exchanged vows in front of a mountain stream. It was picturesque, and we came home, and she started having, almost immediately, she started having some really severe back pain, and she had had chronic back pain, but nothing like this, to the point where we went to the ER one day because she was in dire pain, and she had a very high pain threshold. So I knew if she was asking me to go to the hospital, It was serious. So we went to the hospital, and the ER doc did a CT scan, and he came back and said, "Looks like you're dealing with cancer." And just like that, it was probably a newer doctor. Bedside manner questionable, obviously, to deliver that news. Again, doctors don't get this training either. They don't get training in hard conversations. So I get that piece now. But it was very matter of fact. And then, of course, that started us on her journey, which was the next almost 4 years. We were married in 2014. She got diagnosed shortly after, about 2 weeks after we got home. And the next 4 years, she fought for her life. She was fighting a very rare, very aggressive cancer, leiomyosarcoma. So we were fortunate enough to live in Texas. So we were only a few hours away from one of the best cancer centers, MD Anderson Cancer Center in Houston. And that's where we would go to fight her disease. Unfortunately, she did not win that battle. And in 2018, she died from her disease. So that's kind of my story and how I got into hospice. And then, of course, the hospice education piece. I feel like as a hospice nurse, about 75-80% of our job is education, is educating families on what to expect, on educating patients on what to expect. So education is kind of what I do now for a job. I don't do the bedside so much. Every once in a while I get to do that. But for the most part, I do clinical education for our hospice clinical staff.
So Les, tell me, what do families most often misunderstand about what hospice is and what they're there to do?
So with families, it can vary just because some people have had hospice experiences, right? If it's a family that this is their first time going through this with their loved one, so their loved one is going to die, it's a lot because, again, we don't talk about death. We don't talk about dying. It's very taboo. So we don't talk about it until we absolutely have to. So most families already have some perceptions in their head of what it's going to look like. Largely, that is based on what they've seen in media, right? So movies and TV shows. And I'm sure, Doc, you can attest to the fact that most of the things that we see on TV and in media, as it comes to healthcare in any field, but especially death and dying, is wildly inaccurate. It's just not based in reality most of the time. And so teaching a family that is new to hospice what hospice is going to look like is kind of like starting from the ground up. Except sometimes we already are walking an uphill battle because they already have these conceptions of what's going to happen. So dispelling those myths and introducing what the truth is going to look like.
What are those misconceptions that stand out to you?
The big one is how people physically die at the end and what that end of life last hours and days really looks like, right? Most of the time people see in depictions in movies where someone's laying on the bed and they're having this conversation and they say goodbye and close their eyes and stop breathing. And I, in my 16 years in hospice now, I have never seen that one time. I have seen the natural dying process hundreds and hundreds of times, which is typically where someone becomes unresponsive and really stops communicating, usually days before they actually die. Sometimes you'll get some communication in those last few days. Sometimes there'll be some wakefulness. Sometimes there is a spike of energy that we call terminal lucidity or the rally or the surge. They're all kind of interchangeable terms. And that piece can really, really freak people out. And I heard a statistic that something like 75 to 80% of all people who go through the dying process and die have some form of some of these phenomenon that happen, right? And whether that's that terminal lucidity, whether it's reaching up to the ceiling and talking to people that we can't see, there's some of these phenomenon that are actually very common that we don't see in depictions in movies and TV shows, but we do see in real life. And so preparing them to see that, because it can be jarring and it can be very devastating to people when they show up 2 or 3 days sometimes before someone dies, but they're not able to communicate with them anymore, even though they thought, well, I'd be able to communicate with them all the way till the end. So that's a big piece of the education, and some of the things that we have to overcome when we're educating is getting that reality into their heads so that they know what to expect and it just doesn't really freak them out.
So then how do families know when it's time for hospice? And do most people actually wait longer than they should before initiating the contact?
Yes. In a nutshell, they do wait too long, but it's not their fault. 99% of the time, the physicians for these patients, unfortunately, are not having these conversations early enough. There's not a palliative specialty introduced early on in the process of their chronic or terminal disease, and we have started to see the difference, especially since here in the United States, palliative has really started to take off over the last few years, and so palliative I see it as kind of a bridge that helps hospice, helps do some of that upfront early education, hopefully before they get to hospice. But not everybody has that palliative involvement, and so it can be a challenge. And the trend that I've seen over my 16 years, especially in the last 5 to 6 years or so, has been super late referrals for patients to come to hospice, to even be evaluated or have a discussion about hospice. And that's kind of the message when I'm talking to physicians I'm asking for is, hey, just send them for a conversation if nothing else, right? It's fair to your patient to say you have these options, right? Not everybody is going to want to fight cancer diagnosis, is going to want to fight some of these chronic diseases until they literally can't make decisions and they're not themselves anymore. So they should have these conversations, and that way everybody has a chance to know what they want before we get to that point.
Or at
But
least know what their
referrals are
options
later
are,
and later.
right? So your role in education is not just for families, but also diverse members of the healthcare team potentially. Is palliative care, what's different between palliative care and hospice care?
So the way I look at palliative in my organization, we have hospice and we have a palliative program as well, where we go visit patients in their homes. Most hospitals now, the larger hospitals at least for sure here in the U.S., have a palliative department. So it is really treated like a specialty, right? Just like
Yep.
you'd go to your cardiologist or you'd go to your
Exactly.
endocrinologist. It's a specialty, and so our palliative program, the difference between when you're making that choice, hey, am I going to use the palliative folks here or is it time to talk about hospice, is really about prognosis. And so a prognosis is a physician's basically best guess at how much life someone has to live with a terminal diagnosis as that terminal diagnosis progresses and what stage they're in. And so it's an art to prognosticate, obviously. As a
Yes.
nurse, I cannot prognosticate. It's not within my license to do that, but I've been around long enough to be able to recognize the signs of when we're probably around that 6-month or less prognosis. And so in the United States, for someone to be eligible for hospice, there must be a terminal diagnosis. There must be a physician that says there is a 6-month or less prognosis if that disease is not aggressively treated. So in other words, if we're not doing chemo anymore for cancer, not doing radiation, they've said we're not going to do this anymore, or a physician says you are not benefiting from this, your body can't handle it anymore.
Mhm.
I'd rather us not get the referral when it's at that point, but too often we do. But really, palliative is a specialty that kind of does some of the same things. They focus on pain management. They focus on those symptoms that patients are having either from their disease process or from their disease process coupled with whatever treatment plan they're having. And so they focus on the pain, shortness of breath, right?
Mhm.
Constipation, all those symptomatic things that we focus on in hospice. But In palliative, you're allowed to keep pursuing that aggressive treatment. So you can have palliative at the same time you have an oncology plan of care and keep doing those aggressive treatments. The difference is with hospice, when you come on hospice, you really have to make a decision to forego those aggressive treatments and really seek comfort and palliation of symptoms.
So I can imagine with your experiences that you've already alluded to it, a diverse level of preparedness, but why is hospice so hard for many or some families to accept, even when it may be exactly what mom and dad need?
Well, I could say that in my experience, hospice is hard to accept because death is hard to accept, and I can't sugarcoat it any more than saying hospice really is for patients that are dying, and so I believe the root of the resistance is education, right? And knowledge, and not having that education and knowledge, and acceptance that we are mortal. And specifically, for sure, in the Western Hemisphere, specifically in the United States, because I can speak to that culture, I'm from that culture, we have this idea, especially as Americans, that we are somehow immortal, right? We are going to live forever and our legacy is going to live forever. And while the legacy part can be true, the body part and the physical part is not. None of us make it out of here alive. And so the perception, I think there's a little bit of hubris that goes into some of our culture. And so I think some of that has carried over to end of life and even talking and dealing with death and really coming to that acceptance. I think that's the hardest part, is just accepting that when a patient needs hospice, it does mean that they are at the end of their life.
The other thing is also that as a child, we're thinking of mom and dad. We are no more empowered to change the trajectory as much as we'd like. So when hospice begins, what does the hospice team actually take care of, and what still sort of remains the responsibility of the family?
So that's an excellent question. We get asked this all the time, and this is kind of when any of us as hospice nurses probably that do consultations with families and do education and do admission visits when we're going to admit a patient. The biggest piece of that visit is education, and is setting the expectations for and explaining what hospice does and what we don't do, right? And what we're allowed to do versus what we're not allowed to do. And so here in the United States, the hospice benefit is defined by Medicare, right? We play by the rules of Medicare, regardless of whether they have Medicare or not, right? We're going to follow those same guidelines. And so in the United States, hospice is there to be intermittent care. So I think another one of the common misconceptions with hospice is that once someone is on hospice, someone will literally be at the bedside in their home 24 hours a day. And really nothing could be kind of farther from the truth with hospice. We're really not allowed to be there 24 hours a day, except in very, very specific circumstances that are temporary, right? So I think, again, if we go back to movie depictions, like I've seen movies where it's a hospice patient, and throughout the whole movie, which might span weeks or months, there's a hospice nurse literally at the bedside all the time, right? And so that's a misconception that people have, I think, that we are really not allowed to be the primary caregiver. In fact, one of the rules to come on hospice is there has to be an identified primary caregiver, right? And so we can't act as that primary caregiver. So I think when you think about intermittent care, our nurses, our case managers may come once, twice, 3 times a week. They may come every day to do a visit, depending on where that patient is in their disease trajectory, their journey, and how much support they need, right? Our social workers usually weekly, monthly, sometimes depending on the needs. Sometimes patients and families decline social worker services or chaplain services altogether. The rules of Medicare really say that the only 2 professions that have to be involved, literally have to be involved in that patient's care, are the hospice physician and a nurse, right? So everybody else is optional as far as what the family has to receive. But we offer, obviously, spiritual care through our chaplains, and we offer social worker support, and we offer home health aides. And our home health aides, again, that's kind of another common misconception, is that they're going to come in for blocks of time, like 4, 6, 8 hours, and kind of be sitter services. And we're not allowed to do that either in hospice. Our hospice aides typically will come in. They're there for an hour or two. They're really there to help the patient or provide the patient for their personal care needs, right? Bathing, brushing teeth, oral care, all of those, skin care, washing hair, changing sheets, taking trash out, tidying up. Those are the kinds of things that our hospice aides are there to do. And so I think a lot of the misconception that families and patients have is that they will have somebody that comes in for hours at a time, kind of sits with the patient. And so doing that piece of the education can be challenging as well, because a lot of times people will have these things in their head that this is the care I'm going to receive and this is what it's going to look like. And so actually giving them the truth and the reality can kind of be a little heartbreaking for them sometimes, and heartbreaking for us, because trust me, we would love to be able to do all those things, right? And so that's a big piece of that education. We do provide equipment for patients, right? We provide supplies. So if a patient's incontinent, we're going to provide all those incontinence supplies. We provide the equipment such as beds, over-the-bed tables, all those things that a patient at the end of life is typically going to need. Oxygen, any of those things we supply. And then obviously we supply all the medications that are related to that terminal diagnosis, and specifically those symptoms that arise.
And that's all covered under Medicare?
That's all covered under the Medicare benefit.
Mm-hmm.
And so the way that works, though, is because when Medicare finds out one of their recipients is admitted to hospice, hospice then is responsible for covering basically everything that Medicare would have paid out of pocket and doled out to individual practices or pharmacies, those type of things. And so that's another piece that is an education piece that really, if a patient is a cancer patient and they still want to go see their oncologist and get blood work done, it can be tricky to navigate, because Medicare will see that as part of that aggressive arm of treatment, because they look at it as that patient doesn't need to keep going to those appointments to pursue that aggressive treatment if they're on hospice. And so that's another big piece of education that we do.
So just so our listeners understand, and so I understand clearly as well, does this occur whether you're at hospice at home or whether you're admitted to a hospice facility? Because I know there are standalone hospice facilities as well.
Yeah, so really it applies to either.
Okay.
And again, it's the Medicare benefit. Really with the kind of the nuances and intricacies of someone ending up in, at least here in the United States, in a hospice facility, and we call those inpatient units. Medicare has these things, and not to get too bogged down in the minutia of it, but they have these things with hospice called levels of care. And so the levels of care are routine level of care, which is where we get paid a flat amount per day per patient to take care of all of those patients, all that patient's needs. There is a couple of other levels of care. One is GIP, or general inpatient level of care. And then there's one that's called continuous care, or we call it crisis care sometimes as well. And this is where a patient might be having a symptom exacerbation. So they got some kind of symptom, whether it's nausea, vomiting, pain, any of those symptoms that we treat that are uncontrolled with what we're trying to control them with. And so then that patient, and when I say at home, when we're trying to control something, it's usually largely with oral medications or sublingual medications. Sometimes we'll do topical medications, and sometimes we'll do suppositories and things like that. But typically, if a patient needs IV therapy or sub-Q lines, things like that, or a pain pump, typically we will have a level of care that we call general inpatient, where we can actually take a patient and move them to one of our inpatient units, and they're able to receive care there that's a little more intense than we're able to provide in the home. And we take the burden off that caregiver for trying to give all those medications if that patient needs frequent medication, and specifically more if they need like IV medications and things like that, we use the inpatient unit. If the goal is to keep that patient at home, we might do the same thing, except bring staff in to sit at the bed, administer medications. So we'll have a nurse that we have there on a 24-hour basis until that symptom is managed or manageable. Then Medicare says you can no longer provide that level of care. You have to back off. So people can, and I'm sure you could see where the challenge would be if we start that and then we get a symptom controlled. Sometimes we have to remove ourselves and go back to that intermittent kind of plan of care. And so that can be difficult as well. But that's really the only time we're allowed to kind of take control of administering those medications around the clock and monitoring that patient for those symptoms to be managed. One more level of care, and this ties in really to caregiving more than anything else. Medicare has given us one last level of care, and they call it respite care. And so this is another thing that I really, really try to teach.
You read my mind.
My families. I knew I was getting around to it, right? And respite is a level of care specifically for caregivers. And kind of in my experience and what I know about other areas of healthcare and other ways Medicare pays for healthcare in the United States, this, to my knowledge, is the only place where Medicare carved out a benefit specifically for caregivers. And this is when your loved one is on hospice and you need a break.
You're burned out.
They're burnt out, right? Or, hey, they're the only caregiver here, and a state or two over, their sibling has died, but they can't take that patient with them to the memorial service, the funeral, to help support that end of the family. And so what respite is Medicare says you can take a patient as a hospice, and you can provide primary caregiving duties for that patient for a period up to 5 days, right? So it's 5 midnights, really. So you kind of can stretch that with a first and last day, but you get 5 days of just a break. And what happens is typically hospices will take that patient either to an inpatient unit if they have one, and not all hospices have inpatient units. In fact, the majority do not, or a contracted facility. And what that usually looks like for us as hospices is skilled nursing facilities, right? The caveat is there has to be 24-hour nursing. And so what we'll do is we'll negotiate contracts with local skilled nursing facilities. So we have a variety of those, especially in our area. Our area is a little more spread out. So we have patients that might be 60, 80 miles from another patient. So we try to have contracts where we can place close to their home, place that patient in the skilled nursing facility, and then we go at least every day, if not a couple of times a day, to coordinate with that staff to make sure our patients are being taken care of. And it allows the caregiver to just take a break. They don't have to have an emergency. They don't even have to be at the point of burnout where we're calling an emergency respite. We actually try to encourage folks to plan these things to take a break, and encourage our caregivers to take breaks. And that's what respite care is. So we basically can take that patient, give the caregiver a break, and take the burden of just having to think about, is that person being taken care of?
That sounds like a huge value added part of this whole process. So just so I'm clear, what does hospice actually usually cost families? I mean, what's covered, and then where do out-of-pocket expenses potentially add up? So I'm always worried about the unseen expenses that are in the background.
Right. And this is another thing we get asked, especially at the very beginning when we're sitting down and we're going to sign consents and all that stuff. What's covered, what's not covered, right? So we went kind of through the things that we cover as hospice. Some of the things, the biggest thing that we don't cover, honestly, that people have to come out of their pocket with typically is help with caregiving. It's really because we're not allowed to provide caregiving, right, or primary caregiving for a patient. That family many times and the trend, Doc, is younger and younger, right? I'm seeing specifically with cancer patients, really bad cancers, really young. Both people are already working to try to pay their bills, pay their mortgage, right? And now you've lost that piece, that half of that providing for bills. And so the other person has to typically keep working, right? There's just not a mechanism that we really have to provide for caregivers to be able to be in the homes or stay at home with their loved one. And so some of the hard conversations are that we are intermittent care and that we can't be there 24 hours a day as caregivers, and then trying to help them navigate how to find that and what that looks like. Obviously, different options range from hiring folks to come in for at least periods of time to be with the patient and take care of the patient in their home, all the way to placement in a skilled nursing facility so they have around-the-clock caregivers.
A lot of people hear the word hospice and think it means all treatment stops and everyone is just standing around waiting for death. But just let's review again. What does hospice still actively do, and what's no longer the goal of care?
Right. And so again, another one of those conversations we have in the very beginning is is goals of care, right? What are the goals of care? And so we try to be pretty clear and upfront at the very beginning so that we can find out what that patient and what that family is really looking for and what their expectations really are. With hospice, it doesn't mean we're never going to treat anything. We treat things like infections all the time, right? So as long as a patient is able to take, like oral antibiotics, if they have a urinary tract infection, if they have an upper respiratory infection, we are going to try to usually treat that as long as the patient and family want that, right? Some folks actually say, I don't ever want to take another antibiotic again. It does bad things to my body. I know where this is heading. But being able to have that conversation and learning what their goals are help us to be able to navigate what to do when something comes up or what not to do when something comes up. But obviously, our main focus is going to be symptom management, right? We know that we're not aggressively treating that disease. So they're not getting chemo, radiation. They may have stopped dialysis if they were dialysis dependent, right? And so knowing all of those things and what their goals are for the end of life help us structure individualized plans of care, right? We have to individualize those paths for those people because no two paths look the same.
I can imagine that most patients don't show up alone for these conversations. And obviously, the conversation focus is on a patient-centered approach to defining goals of care. But when there's a misalignment, especially when you sense, and with your experience, you probably can sense it pretty easily, when there's a misalignment of the goals of care discussion with other family members, maybe the caregiver or broader members of the immediate family, what are the red flags that you've come to learn that potentially pose problems to this process?
So, red flags that help me know there is a potential issue are anytime you have a lot of family coming in, usually late in the process, that haven't been around for the entire journey, right? And haven't really been in touch and haven't witnessed the things that usually the primary caregiver member of the family or those that immediate family that's there day in and day out witness. And so a lot of times they haven't had a chance to have any kind of come to terms with acceptance. They are usually, if they're coming in very late, are shocked, usually by the appearance of the patient and where they're at, that they're not communicating, they're not eating, they're not drinking anymore, which we know is expected, right? And we have usually done a lot of education and a lot of work to bring the caregiver and those immediate family members that are there. We've already done a lot of work to bring them along and teach them these things so that they're not in a state of shock. So when we have someone show up pretty late in the process, it's usually knowing that we're going to have to kind of re-educate people and try to bring them up to speed as quick as we can, because we may be at that point only hours or days away. And a family member that comes in and usually, for some reason, they're typically very high anxiety people. So they will come in and they will start asking tons of questions about why something's being done, why it's not being done, et cetera. Why are they like this? And so trying to do that last minute education so that it doesn't interrupt the flow of the care that we've been delivering and the progress we've made with families and the level of comfort that the patient has, because bringing that energy in sometimes can cause the patient to have discomfort. So those are kind of the challenging things. again, to me, it almost always goes back to education, right? And so that's kind of where we start with them.
So once hospice begins, then, look, what are families most likely to keep pushing for, even when the goals of care have been redefined at the entrance to the hospice phase?
Yeah, and so this is another place where we talk about goals of care for the patient, right? And hopefully, ideally, we would have at some point been able to have that conversation with the patient. Obviously, with different diseases, you're not going to have that. With our dementia patients, we are not going to be able to usually have a coherent conversation because typically with dementia patients, we're at the very late stages of dementia, and so we are going to have to trust anything they've put on paper, like advanced directives and last wishes and things like that, and what the primary caregiver or their decision maker at that point, what their goals of care are. So the most challenging things are kind of the mode of being in the normal kind of healthcare continuum, right? Like labs drawn. When are we drawing labs? When are we going to send this off for to be looked at? Shouldn't they go to a specialist appointment, right? And so some of those things where we would just expect, oh, if this happens, then this is where we go to get that done. Shifting that to that's not really what that looks like anymore. The classic one is 911, is calling 911 when something goes sideways or somebody's having difficulty breathing or an exacerbation of a symptom like pain. Panicking, hitting 911, and having an ambulance whisk that patient off to the hospital when typically the goals of care have already kind of lined out that they don't want to go back to the hospital. I would say 95% of our patients that we admit on hospice, one of the specific questions we ask at our admission is, would you want to go back to the hospital if your condition worsens, right? And so typically the answer to that is no. They want to be at home. They're tired of going in and out of the hospital. And so when something goes wrong, though, and that patient is not able to say, hey, stop, I don't want to go to the hospital, many times the caregivers will have that moment of panic and call 911. And so the front side education on that is I don't like to say we become someone's 911 because we can't respond as fast as an ambulance can, and we never will be able to. Our typical time, if you called in the middle of the night at 2 a.m. and got one of my triage nurses, they're going to dispatch an on-call nurse, and it could be up to an hour depending on where they're at. And that's just because of where they're at to get where you are. And depending on the time of day where I'm at, the traffic could cause us an hour commute. So teaching them that, yes, we want to be the person you call instead of 911, but what that response will in reality look like, and that we are going to be there and support them, and we have people on the phone with them the whole time, right? And helping them, over the phone, teach them how to administer medications, which medications to administer, until we can get someone there in front of that family. But that's kind of the biggest piece where we see patients, families typically not really understanding kind of what to do in those situations.
What proportion of your practice or catchment, if you will, or your patient population is hospice at home versus admitted into a hospice care facility? Just so we understand the playing field here.
So probably, if I had to put just a guess number on it, it's somewhere between 95 to 98% of our patients are home hospice patients. It's actually pretty rare that we are using our inpatient unit. Our inpatient unit only has 6 beds. So really, we use that facility for patients that are acutely sick with symptoms that are not able to be managed at home. And that's really what Medicare has said those beds are for, except for when we're using them for respite. So at any given time, 95% of our hospice's census is either at home or in a facility they call home. So an assisted living facility, a skilled nursing facility, and an independent living facility, or their home, obviously. The places where we're actually placing patients in our inpatient unit is actually pretty rare.
So if hospice is happening at home, then Walk me through what a normal day actually looks like for the patient and the caregiver.
So wildly varying, again, obviously, depending on where that patient is, what their disease process is, it can look a lot of different ways. Um, in general, a day for a hospice patient looks like a day for anyone else, except for they are dealing with the end of life. And so, depending on what their disease process is, they're going to have maybe specific symptoms that they deal with on a daily, sometimes not daily, sometimes hourly basis, right? And so try to manage those symptoms is that's the keystone of hospice. For a caregiver, it can look a lot of different ways. I can speak from my experience as a caregiver and
Right.
just the if you are the lone caregiver for sure, or the primary caregiver, you have an immense weight on you, especially for a patient that we know is dying, right? So as a caregiver of a dying patient, it can look like a lot of different things, but really managing everything, and it's so wide spanning. That can be making sure that they have nutrition if they're still taking nutrition, right? And how they're getting that, and that can be a lot of different ways. Maybe they are still able to eat. Maybe they are spoon fed, right? And a lot of our dementia patients get to a place where someone's having to spoon feed them if they're going to eat. And a lot of times that looks like years of that before they even get to hospice. So we see, especially with folks with these long chronic diseases, those caregivers, when we get those families and those patients, they are almost always at a place of approaching burnout. They are just exhausted. And then when they finally have had to make this decision to put their loved one on hospice and say, yes, I'm accepting that they are going to die, you can imagine that weight on your heart and your brain, it's doubled at least, right?
We're going to take a break to hear a few questions and the tradition of the podcast from our illustrious production team, and we'll resume this conversation shortly.
Okay.
Stay tuned.
So one thing that really struck me from the opening of the conversation is that term, terminal lucidity. I've experienced it when we were providing hospice care for my grandmother. About 2 days before she passed, there was this moment that lasted a couple of hours where she was sitting up and she was going through old family photos and she was identifying people from photos from 60 years before that none of us knew. She was these incredible moments. And I think in that moment, we were all so shocked that she had this sort of revival. And I'm wondering, I think some of us thought that, we were probably going to then be dealing with more time, that we would have more time with her. Maybe there was a reversal somehow, and we were going to get this, maybe extra days or weeks. But it only lasted, a couple of hours. So I think that's probably something that really confuses families. Maybe they experience that and they think, okay, maybe the trajectory of this is maybe much longer than we anticipated. Can you just break that down a little bit for me?
Sure. And this is, again, another piece of that education that we try to do, because it's so common. It doesn't happen all the time. It doesn't happen with every patient, obviously, but it happens often enough, right, for us to actually put these things in the literature we write to educate and to give to families. Like literally, we will hand people booklets and pamphlets that talk about the rally or terminal lucidity. Because it can be shocking. And because, again, nobody really ever talks about it the way we just don't talk about death. The way that manifests can look a little different as well. So when you have an experience where someone has that lucid moment, right, where they seemingly wake up and they have conversations, or they look at old photos and they're talking about memories, or expressing certain things to their family members, it can happen hours before they die. It can also happen a few days before they die. I've seen it happen up to a couple of weeks before, and I've seen it happen in one patient that had a moment of it, and then within a few hours they were back to being non-responsive, non-verbal, and about a week later they had it again. And so it doesn't always manifest the same way, and it doesn't manifest at all the time. So what we try to teach is to be looking for that, right? And to not expect it, but to not be shocked or surprised if it happens, and then what it means, right? What it means is it's a surge of energy. I liken it to our bodies kind of being like a phone battery, right? And so if you've ever had a cell phone, which everybody has, that's gotten old, as it gets older, we plug that thing in, it charges, we unplug it, and then before you know it, we're having to plug it back in and recharge it because the battery is not lasting like it used to. So I kind of liken it, I like to use kind of analogies and stories when I'm educating families, because to me it's always more memorable and it's something they can relate to. So I kind of liken it to that sometimes you get that last surge of energy from your battery, right? And so I try to then steer people to looking at that, if it happens, as a gift, right? As a kind of a final gift that we get to spend and make another lucent memory with our loved one. And so then teaching them on the flip side of that, it doesn't mean that they're better. It doesn't mean that they're cured or they're healed. And that's the heartbreaking part, because of course it gives you hope, regardless of whether you're expecting it or not. It can play tricks on your mind that, oh, well, this is what they used to look like. This is how I remember them. And now they're back to that, right? And so the teaching ahead of that is so important, to at least have them be able to brace themselves and their hearts for seeing that, but also understanding that it doesn't mean that they're getting better.
Right. Thanks for explaining that.
And that sounds like a huge sort of thing to warn people about, so that there's so much anticipatory grieving, which can be healthy as part of the process of letting go. And you don't want those moments to almost make the caregiver feel like that exercise was in vain because, look, they're back.
Exactly. Or regret the decision that they made. They may have had to make days or weeks before to place their loved one on hospice. It will give you doubts. And so, again, with that anticipatory grief, and I think any of us that have been through folks with chronic diseases and these long diseases, we go through that anticipatory grief, whether we know we're going through it or not. And so knowing it on this side now, yes, that there is a fear that it will hinder some of the progress they've made and the work they've done, sometimes even without knowing they've done it. That moment can cause them to kind of take a step back, because then they start having that self-doubt.
Folks, we're back from what I like to call the producer's moment. Some reflective questions from those closestly or most closely invested in the podcast, who are listening in to an amazing conversation. And we think it brings a level of openness and honesty to this discussion. I'd like to take things a little bit down a bit of a different path. How do we talk honestly about grief and exhaustion, and even the notion of potentially relief around the corner that many caregivers feel once hospice begins?
So when we're talking about grief, again, I found that from being widowed twice, again, you feel very alone, right? You feel very alone and isolated in your grief, almost regardless of who you have around you as support, because you have suffered the loss and you internalize that loss a lot, right? The folks that are coming onto hospice, especially with those loved ones that have had these long chronic diseases and they are coming to an end, many times they have never even heard of what anticipatory grief is. And so they don't know, but they're living it already, right? And they're walking in it already. So what I've found is just, again, the same thing with hospice and with end of life and with death and dying goes hand in hand with grief as far as we don't talk about it, right? Grief is one of those things where we like to get through the death, we like to do the memorial service, and then we're moving on with our lives, right? And so for the person who is that primary caregiver, the spouse, child, mother, father, whatever that relationship was, for them, there is no just moving on. We never move on. We never move on when we lose someone. We like to say in the widow community that we move forward, right? So we're still moving, but we're not moving on from that person. That person is always going to be a part of who we are. Loss, death changes the living, right? It changes the survivors, right? I call myself a survivor of death, not because I had a near-death experience, because I walked through the people that I love the most leaving this world and dying, right? And when I looked back, I could see that anticipatory grief, right? I could see that I had already done a lot of grief work by the time my loved one died. And so I think talking about it and saying, and what I try to do on my platform is I try to educate on hospice, but because of my position of being widowed twice and the reason why I do end of life care and education is because I had those experiences and I had that grief and I lived with that grief and I still carry that grief. But same thing, we don't talk about end of life, we don't talk about death, and we really don't talk about grief much, and we romanticize it sometimes. And so the reality is that it feels like you're in a silo, it feels like you're very isolated, and the rest of the world is moving by at light speed, and you are stuck. And that's how it feels. But if we talk about it, and one of the things I try to present on my platform is the message that you're not alone, right? It feels like you're alone, right? But you're not. There are thousands, hundreds of thousands, millions of people who have walked this path and are walking this path with people they love. And so grief is one of those things that we don't have to feel isolated. We need connection, right? And the connection helps us be able to heal because we're healing together, right? And we're not feeling so isolated.
As people who are part of the inner circle of someone who's a caregiver and going through anticipatory grief or even the process of grieving after they've just lost someone, there's always that sort of tension about how do I show up for that person? But from some things that I've read and heard about, sometimes it's just letting that person know that I'm here, I'm present, and that's okay, and that's all you need to be. What are your thoughts about that?
So I've seen a lot and I've lived a lot in this vein. So what I experienced in both of my wives' deaths, after both of my wives' deaths, was people wanting to do things for you, right? So they want to bring you food or they want to do errands for you, which is great, right? Some of that can be helpful. The way I looked at it is, most of the people who wanted to do those things weren't wanting to do those things when we were going through the bulk of and the heavy lifting of caregiving. But it's something they can feel like they can do to help me or help the grieving get past this loss, right? And there is no getting past the loss, and that's what they understand. It's hard to navigate, right? Because as someone who I love that people want to do things for me. I love and I appreciate the effort. But at the same time, those things are not really what a freshly grieving person is needing, right? To me, it was just knowing that I wasn't completely alone. Even the times I was alone, that I had someone or a group of people that I could turn to if I was in need of, whether it was a physical thing or just needing to scream, needing to cry, right? Needing to cuss, right? Like just needing to vent. It's important to be there for people that are grieving in that way. That can almost be the most important thing. And how you do that is you just let them know, right? it's okay to be honest. One of the most annoying things I think when I was going through grief was hearing the same phrases over and over again. I'm so sorry. I can't imagine. And yes, those are the things we say, and it's totally okay to say those things, right? But at some point, they become cliche, just washed out gray language in the minds of those who are walking in grief, right? I would much rather, and this is what I tell people to say, just be honest and say, hey, I don't have the words and I don't know what you're going through. I just want you to know I'm really sorry that you're going through this. I'm sorry you lost your person. And I don't know if there's anything you need, and I'm not going to be pushy and just bring you things or do things for you. But I want you to know that I will have my phone on by my bedside if you need to call me at 2 a.m. just to cry. I don't care if you even talk, right? I'll just be there for you in whatever way you need me to be there. And then leaving it in the hands of the grieving person, because then we at least know we have somebody that if we feel like we're in a point of isolation, we know we at least have someone to reach out to. And so I think that's kind of the most important thing. When you're navigating grief, it is a uniquely individual journey. Everybody does it different. There are commonalities, but it's unique to every person. So leaving it up to that person, you know, it's hard to do, right? Because we always want to be doing something, especially people that are empaths and people that are caregivers themselves. They want to turn around and caregive for the people that are grieving.
They're used to that mode.
Yeah. Sometimes it's just knowing when to draw your boundary for that person, right? And not overstepping into making them uncomfortable, and having to say, no, I really don't want, like, I don't want to push someone away, but also don't want you to be so close in my business when I feel like I need space, right? And for a lot of caregivers, we never get space until that person dies sometimes, right? We never get moments alone. We never sometimes get more than 2 minutes in a shower in between, somebody's napping. We're going to get in the shower, take a shower real quick, jump out and hope that something hasn't happened in the 2 minutes. That's the mode we live in. So when you get to the grieving part, there's almost a separation on purpose. Like, I'm going to isolate myself a little bit on purpose for my own peace of mind, just because I need silence. Sometimes you just need silence for a little while, right? But knowing that if in my silence I need something, I have somewhere to go and I have someone to reach out to, that's the most powerful thing, I think, for a grieving person.
So what I'm hearing is that if you're offering yourself as a person for someone who's grieving, a friend, a community member, maybe even extended family who you don't see very often, but offer it in an undifferentiated state and let the person grieving define the terms. And that's where the power of your presence and your offering of yourself as a person for that will really have the best chance of shining.
Absolutely, yeah.
Les, caregivers in the final stage of hospice sometimes reach that point where they're quietly thinking, I don't know how much longer I can keep this going. I need this to be over. When someone thinks like that, what does it actually mean and represent?
It means that they have given everything they have to give. And as caregivers, when you're in that situation, you do whatever you have to do. I was just talking with my wife earlier about looking back, and when I look back at myself, I see a different person, right? I wasn't the same person then that I am now. For people that go through these kinds of losses and go through this kind of grief and live the life of a caregiver, taking care of people that eventually die, right? It changes us. We just aren't the same people anymore. Your perspective on life is usually completely changed or modified. Your perspective on friendships, your perspective on family relations becomes different because you've been through something incredibly difficult and you learn to recognize the people that were there for that journey and the people that weren't, except for when it was convenient for them to be there or when they got something out of being there, whether that was just the pats on their own backs from themselves, right? But you learn very quickly who your people are that you can rely on and that you can go to, and so it changes you and it changes those relationships forever. And so I think part of it, a part of grieving, is just that you're a different person when you come out of it, and so I think another part is when you do look back, and for me, I'm enough years removed where I can literally look back and go, "Wow, I was a completely different person. This changed me and made me into who I am now." But I don't really recognize that person, but I grieve for that person, and I feel a little sad for that person, right? Because that person went through literal hell, right? And still ended up losing the person that mattered most to them. And so the way I inherently have to look at that now for myself is that I have to make meaning of that, right? I have to make meaning of those losses and the experience I've had. And so that's where this comes from. That's why I created a platform, why I'm trying to do end-of-life education, and education on grieving and support for those that are grieving and walking through it.
That's really powerful, and how meaning just surges to the forefront of maybe the why of all of this. Why are you doing this? To make sure that the meaning stays alive and
Right.
perhaps in a reinvented form, because meaning was different then.
Absolutely. Mm-hmm.
When someone's dying in hospice, what do families gain from being present at the end? But what also makes those moments so hard for some people to face?
Well, again, our perception of death, right? And our fear of death and the fear of the unknown, regardless of what spiritual views you had. I see people that they've been that subscribe to one religion or another for their whole lives, and they still have questions at the end, right? And they question the meaning, they question reality. And families for sure do this, right? Families and caregivers and loved ones of these patients that are dying classically struggle with spiritual and existential meaning kind of issues at the end of life. And just kind of realizing that it's okay to have those feelings, and it's okay to have those questions and feel free to explore that, I think is important for people. I don't know that people naturally have an inclination to do that in the moment. It's emotional, right? And so you get anger at God or whatever belief system you have, distrust maybe. You can encounter all those things. The reason why I encourage people, family members, to be there at the end is multifaceted, right? One is regret, because classically, if people are given that opportunity and they decline that opportunity because they don't feel like they can just deal with it, or they don't want to face it, or they don't want to see somebody die. Classically, it leads to regret later on in life. And that could be days later, it could be years later, but just not ever having faced that and having the courage to walk in that room, to hold their loved one's hand and say goodbye. And to me, those moments are the gifts, right? Those are the gifts we give to our loved ones. And they're the gifts we give to ourselves, right? To kind of make a piece of closure at that point, to be there at the end, and and it means something to the other family members that are there, right? It's very noticeable who's not there and who is, and so there can be family dynamics that come into that as well, which we as hospice try to navigate. Not all families, in fact, most families aren't 100% in alignment with goals and with where they're at in the process and acceptance. So navigating that can be a challenge for us as well, but we still want to be able to touch all the people, if we can, that are involved and love that patient, because we'd like to be able to help them in whatever way we can in their journey.
So building on that, like having witnessed so many final moments what tends to make a death feel peaceful, but contrary, what also tends to leave family carrying regret forward and after?
So let me make sure I'm understanding your question. What makes the death peaceful, but they still have regrets later? Is that
Or
what you're asking?
comparatively, what makes a death peaceful for the patient and the family, but then what tends to leave or what can happen that tends to leave a family carrying regret afterwards and forwards?
So I have seen a lot of death. I've seen a lot of what I would call good deaths, right? A good death is basically what that person and what that family expect it to be, whatever that outcome is. But for me as a hospice nurse, a good death for me is that the patient's symptoms at the end of life are well managed, that they're not uncomfortable physically, and they're not needing to stress when they're approaching the end of life and when they die, and that there is peace, right? That they're in a place of peace, and I'm not talking about internal peace. I can't. I have no way of judging that usually, but that the environment, the home, right, has peace in it, and so that's where it can be very challenging with family members, especially in the last few days or hours of life. You'll have people coming in at the last moment. And that's where we talked about earlier with that education and kind of trying to manage the dynamics that are coming in, and maintaining that kind of sense of peace. And peace may look like whatever it looks like for that family and that patient. But for me, it's just having a sense of accord, right? And that everyone is at least accepting of what's going on, regardless of where they're at in their pre-grieving or their anticipatory grieving. That at least for those moments, those last moments, that we can have a peaceful environment, whatever that looks like for the family. As far as regret, it's kind of the other end of that, of not having any kind of peace, any kind of resolution. It's if family members, and this is another problem we face sometimes, is that we see symptoms that are happening, specifically pain, shortness of breath, those kind of classic, very end of life issues, and we know what to do to help control those symptoms and get those symptoms under control. But family becomes resistant, right? So resistant to comfort medications like morphine or Ativan, the things that are in our toolboxes to help that patient be physically comfortable. And so sometimes we have patients that I have seen that did die before I could get those symptoms under control because of resistance for families. And I do believe that sometimes that can cause regret later for family members.
A lot of people say that they want to die at home. In your experience, does where a person dies actually matter? And how should families sort of process and think about that wish of where their loved one wants to die?
So it can be a complicated question as well, right? For most patients, if a patient is lucid when we are admitting them and they're able to make their own decisions, this is another big piece of the conversation that we have, is where, we're talking about all their final wishes, and one of the final wishes is, where do you want to depart this life physically, right? Do you want to be in your home? Are you okay with being in a facility? What is your preference? And it can vary. Like, we have patients that say, yes, I want to die here. I've been in this house for 50 years. I've raised my kids in this house. This is where I want to die. And we have patients that look at their spouse and their family and say, I don't want to leave the memory of me dying in this house in your minds. And they want to go somewhere else to die. And so that can be tricky to navigate as well, because like I said, with Medicare and hospice, we have to have a reason, and usually that's a pretty extreme reason, to move someone out of their home and into one of our facilities, right? So it can be tricky to navigate, but we try to honor the wishes of the patient. And so if they want to stay at home, our goal is going to be to try to keep them in their home until they die.
So, for the caregiver who's got a loved one in hospice, What are the signs? Walk me through this that tell you that the process of dying is coming to a close and death may be near.
So there's kind of a few stages that we have labeled. Someone labeled at some point, and kind of the hallmark of when we go from having months, weeks to months, right, to having days to weeks, and then hours to days. That's kind of how I try to present it to my patients and families, because there are kind of these phases that we go through. The hallmark, though, of when I know we have hours to days, usually 5 to 7 days, from the point of someone when they're not taking any nutrition or hydration in, right? So they're not eating or drinking at all. That's completely stopped. Our bodies are just on a time clock at that point. I would be on a time clock right now if I voluntarily stopped eating and drinking and took nothing into my body. Our bodies can, and my body in particular, would have a little more fat, right, to live off of. So the nutrition isn't that big of a thing. But if we stop drinking and hydrating, we can very quickly become dehydrated because our body has no mechanism to rehydrate itself, right? We have to either be drinking fluids or we have to have it put into our bodies artificially. And so once we know that a patient is no longer eating or drinking, then it's much more reliable for me to be able to go to a family and say, hey, we are now down to hours or days, right? We're the human body, and usually I will do some education on, the human body in a healthy person, you're 5 to 10 days kind of max. We usually say 5 to 7 days, right? And so for someone that's already terminal, that's already probably just been taking sips of fluid and bites of food here and there,
Already malnourished.
they're
Yep.
already malnourished, right? They've already probably been losing weight. They're already probably on the edge of dehydration, so it doesn't take nearly as long. And that's really the moment where I try to put families on, I hate to say high alert, because high alert comes with like, stress and mental burden, but I try to make them aware, right? Like, our time is definitely more limited now. And sometimes those families have been waiting to call other members of the family in. And that's typically when I'll say, if it was me in your shoes, when my loved one stopped eating and drinking would be when I would say, hey, rest of the family, it may be time to come and say what you need to say, or not, whatever they decide to do. But I like to as a nurse, as a case manager, when I was seeing patients, that's classically the point that would tell me it's time, right? We're getting close.
I think, in those moments, it really sort of embodies the skill set that you have to nurture a calm awareness.
Yeah. And that's it's a learned skill for sure, right? It's from having hundreds of those conversations and learning the nuances of different people and how different people react to the same information being given to them. So it's very interesting. It's been a very interesting path and self-revelation, right? And learning how to have those conversations. And it takes time. And I think that's a challenge for us with our newer hospice nurses, is they've never been given any education on how to have those conversations, right? Physicians really don't get that education on how to have those hard conversations. And so a lot of times it's in the beginning, it's finding a good mentor that can help you do that. And then just learning, sometimes it's trial and error. I've put my foot in my mouth, I'm sure, more times than I can count.
Well, I mean, there's, you have a curriculum which informs you of what your skill set needs to evolve to, but, the mentorship is a longitudinal relationship where that skill set gets refined. There's no question.
No question.
For the caregivers listening, and you touched on this, but I think it's really important that they understand, but when you have hours to days to live, are you feeling thirst and are you feeling hunger the way we feel it?
Right. And a huge piece of the education with nutrition and hydration is that there is a part of our brain that basically drives hunger and thirst. And really that part of the brain kind of just goes to the background, shuts off. And dying patients don't have hunger and thirst the way we have hunger and thirst. And so the other thing I try to kind of teach people is the things that we see outwardly, right? And we can see outward decline. We see outward signs of aging, right? Our hair turns colors. We start losing our hair. We start losing muscle mass as we get older. These things we are used to seeing in our loved ones, and we're used to looking in the mirror and seeing. But what people don't think about is also as we age, and also as we get older and more advanced and things start going sideways, right? We can see the outside. We can see our skin get wrinkled. We can see our hair get gray. But what you have to think is the same thing is happening to our body on the inside. Our organs are aging. Our systems, the systems that keep our body going, the mechanical systems, have wear and tear on them, right? And that's what part of the healthcare continuum is, right? Is like taking our cars into the shop for maintenance so we get more life out of that car. And so doing the education that at the end of life, a lot of different things happen that aren't normal for everyday life, and nutrition and hydration is one of the biggest pieces because it's so closely tied to life, right? Eat, drink, and be merry, right? Like when we get together, when we have gatherings, is there ever a gathering we go to with our families that we're not having food of some sort, drinks? When we celebrate things, we have food, we have drink. And so it's so ingrained in our life, and our bodies have to have it to keep going from day to day, that when someone stops taking in food and hydration altogether, it's another one of those things that can be very shocking to watch, right? Because it's not normal to us, but it is normal for a dying patient. Their bodies at some point are no longer even able to process the food if we put it in them artificially. We
Right.
have patients that have PEG tubes, which are feeding tubes that are inserted in their abdomen directly into their stomach. And when those people start dying, I have seen it time and time and time again where their family will insist, no, they need to keep getting their tube feedings. And what happens is the body and the organs are shutting down, and the bowels are slowing down to the point where there's almost no peristalsis. There's almost no movement,
through the bowel.
in that tube. And so that can actually cause those feedings to back up in their stomach, and then they can
Into the
actually
lungs.
aspirate or choke
Yep.
on those feedings. And so
Mhm.
I've seen it so many times. And unfortunately, it happens classically with our dementia patients, right? Our Alzheimer's patients at the end of life. And so doing that education is tricky too, right? Of teaching people when they come onto hospice as an Alzheimer's patient, and they've maybe already been in the hospital twice this year because they had an aspiration and now they have a feeding tube. And then having to tell the family, I know what you did with this feeding tube, you did out of love and out of trying to keep them here longer, right? But at some point, their body is not even going to accept that. And the death that they could have if they aspirate on that feeding looks worse than a death without it, right? A natural death where there's no fluid in the lungs. It's not a good death to witness from the family's perspective either. And sometimes we can educate and get them to back off of that. And sometimes we can't. And unfortunately, I think that's another one of those things that can cause regret in people later on.
So other than not eating and not seeking to drink, are there other normal signs of the body shutting down as death is approaching that caregivers sometimes misread as suffering that they have to witness?
Yes. There's a few, right? There's a phenomenon that can happen. It doesn't happen with everybody. Again, most of the things that I talk about with education doesn't happen every time. And that's why it's so challenging to do some of this education.
It's not rubber stamp. Yep.
It's not rubber stamp. There is no, this is how it happens every time. It'd be great if there was, right? But it's not, and it never will be. We're human. One of the things that happens, we call mottling, and that's Mottling, not modeling, like putting together a model. And what that is usually a discoloration of the skin. A lot of times it will look like on lighter color folks like me, it would look like kind of like a spider web and almost a purplish discoloration.
Yep.
We see that happen a lot of times in the extremities first, and classically in the feet. Think about circulation, because this is a circulation issue. And what's happening is, as the body gets weaker, the body is going to recognize that we're not putting fluids in there, so we're becoming more dehydrated, right? So there's less volume in our circulatory system, and so then to try to compensate for that and to save the vital organs, really is technically what's happening. The body will say, okay, the feet, we don't really need those. Those aren't vital, but everything here is, right? Our heart, our lungs, those are the main ones, right? And so it will shunt circulation away from those extremities
Central.
to the heart, right, and the vital organs. And so what happens is then it looks like that there's not getting blood, and they're getting less blood to those areas, right? Because the body's doing it on purpose, right? It's trying to salvage the vital organs, and it can be cool to the touch as well. And so those two things, that strange discoloration, and a lot of times it'll start in the toes and it can start just creeping up the legs. I've seen a patient that was mottled all over their body. I've seen people that didn't have any mottling at all when they died, and I've seen people that just had the tips of their toes. So it varies, but when they see that, they're going to almost, without any education for sure, they're going to think that equates to some kind of suffering, right? Because it doesn't look natural. That's one of the main things that happens at the end of life. One of the other things we call the death rattle, or terminal secretions, or excessive secretions, and this is when the body again is overproducing secretions. And so typically folks will have a lot of secretions in their mouth, and at some point they lose the ability to consciously or subconsciously swallow. And so those secretions that we would normally cough up or spit out sit in their mouth, and sometimes towards the back of their throat, and it can sound like a gurgling, right? Or a very loud snore, a wet snore. And that is one of those things that, as a caregiver, even as someone that was a hospice nurse, when my mother had this a couple of years ago when she was dying, was troubling to me, right? Even though I could look at her and say, she's comfortable, this isn't equating to suffering, I see no signs of suffering. It causes the family distress because the sound of it is so unnatural that it can be very distressing. So my education for families there is, you may see this, you may hear this. It doesn't equate to suffering, right? And try to cut those things off at the pass by educating before they even happen.
So I'd like to, in this last couple of minutes of our discussion today, I'd like you to take me on a little bit of a walk and share with us what those first moments are like when someone dies in hospice, and what actually happens, and what families need to understand and be prepared to experience in that moment.
So when I'm teaching people about the actual moment of death and what happens after death, again, lots of misconceptions because of our portrayal in the media of what death looks like and what after death looks like, right? But in reality, typically someone that dies a natural death, again, we have identified usually a week or maybe a little bit further ahead of time that they've stopped eating and drinking. And so now what we do as hospice, typically what good hospices will do, is really recognize that moment, and that this is the time where the family and the caregiver is going to need more support, right? So typically what I would be doing as a case manager, if I recognize someone's in those last hours to days of life, is I would be increasing the frequency of my visits to that family and that patient, putting my eyes on them at least every day, and kind of virtually holding the hands of the caregivers and walking them down that path of what to expect. And at the moment of death, usually, again, we've had sometimes a day or two of a patient that's going through what we call the actively dying phase. And this is where they are not going to be waking up, talking. They're in basically a comatose state. Their breathing patterns have probably changed. And another piece of the education at the end of life is the breathing patterns that we see sometimes at the end of life that aren't what we would think of as natural breathing patterns, but it is natural for a dying person because it's another one of those processes that the body goes through as compensation, right? The body's trying to compensate and get back to what we call equilibrium, right? Normalcy. But it's not a normal part of life, and it never is, right? This is, I've heard people talking about, and especially death doulas talking about how we labor out of life, right? Same way we labor to come into life, there is a part of leaving this world that is a labor as well. And those are some of the changes that we see. So typically by the time we get down to those hours that are left, we are doing a lot of education. We're doing a lot of emotional support. We are talking to the caregiver and letting them know, hey, if they stop breathing, call us, right? We want to know as soon as they stop breathing. And when they stop breathing, we've already put into place that we're not going to come in and try to resuscitate them, remember? And so we do a lot of circling back to those original conversations of goals of care, because that's another one of those places where there are plenty of red flags that can pop up for when this person actually dies. There are going to be maybe some issues, right? And so the last thing someone wants to do at the end of life that wants to have a natural death is for them to die and then you to call 911 and have someone come and attempt CPR. It's not a pleasant thing to witness. Again, it's one of those things that we see on TV that is almost as far removed from reality as it can be. It is a brutal thing that can happen at the end of life, and I hate to see it happen. So big piece of the education is like, hey, they are going to stop breathing, and that's okay. That's where we're headed. But when that happens, you're not alone. You're going to call me and we're going to come. No matter what time of day it is, we're going to come out and we're going to be with you, right? And so sometimes we've already had the conversation of the technical things that happen where we are listening, we're making sure we're pronouncing, we're calling our physician and letting them know. We may be calling the funeral home. We may, in some areas of the country, actually be having to call the medical examiner in our county to report the death. There are technical things that happen. And so the big piece of caregiver support there is making sure they understand the things that are happening or are going to happen, and then figuring out, hopefully ahead of time, what their support system is going to look like and how we can help make sure that that support system is there or on the way to be there with them, if that is what their support desire is, right? Some people, when my wife died, I wanted no people around me, right? I knew it was coming. I had worked through a lot of anticipatory grief. I had accepted it, and I just needed time alone, right? And some people need that. So being a kind of learning how to navigate anticipating what their needs are going to be can be challenging as well. But really, at the very end of life, it's a lot of the moment isn't quite as dramatic as like media makes it out to be, right? There's usually not a final gasp where they're not looking up and then they close their eyes and they die. The reality is when people die, there are certain body processes that happen. Their jaw, their facial muscles will relax. Usually their eyes will be open or partially open, and their mouth, their jaw will be slack and their mouth will be open. Physically, if you are not expecting that to happen and to see that, it can be very jarring. So we try to prepare our families for that as well by giving them that information. As a family member, I can tell you before I was a nurse and when I had my first experience, one of the most valuable things was the education that I was given and the things that I was told to expect, because had I not at least expected that those things might happen, when I saw them, I for sure would have panicked, and so there shouldn't be any surprise that families do that a lot. If we're not doing our due diligence and educating, then that's what's going to happen. And I hope that answered your question.
Absolutely.
I know it was very verbose, sorry.
For the caregiver listening right now, whose loved one may be nearing death in hospice, what's the one thing you most want them to understand before that moment comes?
That what they're doing and the support they are giving and the love they are giving, the things that we talk about doing, the words they're speaking, even though they may not be getting any kind of response from the person they're speaking to, are important and they're valuable, and not just valuable to the patient, but almost more valuable to the person saying those words, right? And so that's really the emotional piece that I try to really encourage families to do, is the emotional pieces that are meaningful, and that those things will continue to have meaning for them for the rest of their life, right? And then the big thing that I want people to know is they're not alone, right? They're not the first people to ever lose a spouse, a parent, a child, right? They're not alone in their loss. And that's kind of the main message that I want people to understand, right? Whatever that looks like, you are not alone, right? No matter what you're going through.
Les, I want to personally thank you for what you do and for your commitment to education. And that wraps up this week's episode of the Caregivers podcast. Thank you for being here. Thank you for listening. And we'll see you next time.
Thanks, Doc.
Thank you. If this conversation is meeting you in a tender place, I hope it has made hospice feel a little less frightening and a little more understandable. Les, thank you for helping us talk about one of the hardest parts of caregiving with honesty and, most importantly, humanity. And if this episode meant something to you, please subscribe to the Caregivers podcast on Apple Podcasts, Spotify, or wherever you listen. It's free, takes a second, and it's the best way to support the show. We'll see you again next week. Thanks for listening. Thanks for watching. Thanks for caring. Before we wrap up, I wanted to remind you of something important. The conversations you hear on this podcast are here to inform, to support, to spark reflection. They're not a substitute for professional medical advice, care, therapy, or crisis services. Listening to this podcast does not create a doctor-patient or caregiver-client relationship between us. If you're facing a medical concern, health challenge, a mental health challenge, or a caregiving situation that needs guidance, I encourage you to reach out to a qualified professional who knows your story. If you're ever in crisis, please don't wait. Call your local emergency number or recognize crisis hotline right away. You deserve real-time help and support. The views you hear on this show, whether from me or my guests, are our own. They don't necessarily reflect any organizations we work with, or are part of, or have worked with, or been part of in the past. This podcast is an independent production. It's not tied to any hospital, university, or healthcare system. Thank you for being here, for listening, and most of all, for taking the time to care for yourself while you continue to care for others. I look forward to hearing from you.